through, ad- through advocacy, academic discussions, and leadership opportunities. Since its inception on Women's Day, March 8th, 2024, it has grown over to 2,000 medical students across India. And finally, now it's my privilege to introduce our distinguished panelists. Our first panelist is Dr. Sebanti Ghosh, a public health and nutrition leader with over 25 years of experience. She has led programs with Alive and Thrive, WHO, UNICEF, and IPE Global, and served on the Government of India's Technical Expert Committee, shaping key nutrition policies. Her work has been pivotal in ensuring last minute nutrition delivery and strengthening India's health system. We are very honored to have you amongst us, Dr. Ghosh. Our next panelist is Mr. Kratu Goel, a global health economist and policy consultant at WHO headquarters in Geneva. He has led the migration of One Health tool and developed the UHC Compendium, a database of over 3,500 health interventions used worldwide. His recent publications include the WHO HTA survey results and a BMJ Global Health paper on including abortion-related care in national health benefit packages. We're also very honored to have you amongst us today, sir. Thank you so much for joining. Our next panelist is Dr. Metu Pradeep Reddy, a pediatrician and a neonatologist with more than 3 decades of experience, an alumnus of AFMC Pune, AIMS New Delhi, and the London School of Tropical Medicine. He has served in the armed forces as UNICEF's state consultant in Telangana and Andhra Pradesh. He played a key role in scaling immunization drives like Mission Indradhanush and establishing special newborn care units across the country. We are truly honored to have such esteemed panel with us today, and we look forward to their insights on this important topic. As we set the stage for today's discussion, it's important to highlight the core theme, breastfeeding awareness, but with a different point of view. Today's session focuses on nurturing rights, a theme that emphasizes the fundamental rights of mothers and children, from breastfeeding and maternal care to supportive social and legal frameworks. It also highlights the vital role of fathers and families in creating an environment of shared responsibility, dignity, and equity, ensuring that the nurturing becomes a collective effort for the well being of every child. Our panel today will help us explore these different dimensions of nurturing rights and discuss how we can approach them with greater empathy, clarity, and collective commitment. So,
Nisa, if I may interrupt you, I'd like to say a few words. Um, Nisa, first and foremost, good evening, everyone. I'm so sorry for the interruption, but I would like to first take a few moments to thank Dr. Ghosh and Mr. Goel for gracing this webinar with their presence and being so cooperative and supportive throughout our correspondence. I personally have had the pleasure of being judged by them and receiving their valuable insights towards this entire towards my journey of clinical and public health interest. So very thankful that they took out the time. Um, I would also like to announce that Dr. Reddy is unavailable at the moment as he is facing some technical difficulties. However, he has put shared a very comprehensive presentation regarding the points he wished to cover with the slide numbers, which were of utmost importance to hone us clinicians instincts for advocacy and for us to note in our clinical practice. And therefore, we would like to thank Dr. Ghosh and Mr. Goel for being here, and the material for which Dr. Reddy wanted to share will be sent across on the WhatsApp group. Furthermore, Dr. Ghosh, I think, has also requested um, for her questions maybe to be taken up a little earlier as she is unwell and yet has very graciously agreed to impart her knowledge and insights with us. So, Mr. Goel, if that's okay with you, would could we please take up Dr. Ghosh's questions first and then go on? to
Yeah, yeah,
your
sure, no problem.
thank you so much. Thank you. All right. Nisa, and everyone, thank you so much for joining in. My name is Shivani Nirgurkar. I'm one of the co-founders of SIMSOG. And I am very, very thankful to Dr. Ghosh and Mr. Goel for being here. And good luck, everyone. And I hope you all take a treasure trove of knowledge from this webinar. Any doubts, please direct them to SIMSOG. We'd be happy to correspond on your behalf. And once again, all the best to everyone.
So, finally, starting off with a panel discussion. The first question, as we will be starting with the family and social dynamics theme, I will be directed to Dr. Ghosh. So, breastfeeding in public remains a taboo in India, with mothers facing shaming and harassment. So, what social and cultural factors drive this stigma, and how can we address the internalized barriers in mothers themselves, busting myths and ensuring better compliance?
First of all, thank you to the SIMSOC team. Am I audible?
Yes, yes, Dr.
Um,
Ghosh.
and congratulations for you as medical students organizing this kind of a panel discussion with a very different lens of nurturing care for newborn care, focusing on optimal breastfeeding and looking at the various socio-cultural dimensions. So I'm really happy about that. And I apologize of my being not well disposed suddenly today. And thank you, Goelji, that you kindly accommodated this request of me coming in first and taking the questions. So, without much ado, let me answer the question that Nisa has put up. I think this is basically a patriarchal mindset that plays out. You know, we consider breastfeeding solely as the woman's or the mother's private issue. And that's why, we do not create that kind of a open social ecosystem where the woman can breastfeed with pride. And I see this more in the urban context also. Particularly, I see it across workplaces. The variation across rural urban geographies may not be very um, distinct, but I would go to the roots of patriarchy and considering breastfeeding as something that the mother is supposed to be doing, and it is part of mother's health and responsibility, and we always relegate women's health or mother's health um, to a private sphere, and we very often do not look at it from an aspirational angle. And I think you have questions where you would be asking me about the role of the family, the society, uh, because if we want to change this mindset, we must remember that it takes a village to breastfeed. It is a collective responsibility for each one of us across various ecosystems. So, whether it is the health system, the family ecosystem, the community ecosystem, the workplace ecosystem, if it has to be a whole of society, whole of government approach to break this taboo that, and we have this very unfortunate practice of staring back, because of, looking at woman as a body, and then the issue of the privacy or the control over that body. I'll stop here. Any further questions? Happy to take.
So, what practical steps can hospitals take to provide the safe spaces for mothers where they can not only share their physical difficulties but also emotional struggles of breastfeeding?
Uh, See, I think we very often consider that breastfeeding is something that comes naturally. Undoubtedly, it is a natural process related to childbirth. I am not talking about over medicalizing childbirth or breastfeeding, which has also happened in the health system, including without any disrespect in the private health system. But um, what happens is that a woman, a mother, a new mother, or maybe a first time mother needs skilled counseling and support, you know, to breastfeed. And she needs to get the right guidance, the answers to the problems that she is facing. And very often, family members who may not be fully aware, or with the Google Master coming in the urban areas, they tend to depend on that, and they often do not get that space or support within our health system, because the stay is limited post a normal delivery, and even the limited stay, postpartum care and supporting the establishment of breastfeeding, or supporting the mother with the right counseling during discharge, often is neglected. And the continuum of care at the community level, because the health system has a limited contact point, and when the newborn later on comes in for immunization or well baby visits, breastfeeding or infant and young child feeding related practices are very often the backbenchers. So we have this disconnect. And the most important thing when you are asking about the emotional support, we have the evidence how the mother's psychosocial health, the perinatal mental health matters, not just after giving birth to a child, but starting right from pregnancy. And it again brings us back to the family, the health ecosystem, family, the community, what kind of support she gets if she is suffering from a perinatal depression, if during pregnancy she is facing a psychosocial health issue. Are we ever bothered to look at her history, which are red flags for poor emotional and mental health and well being? And our health system is not at all capacitated or prepared, except in certain institutes, in certain states. There has been a positive effort that happened at the Ministry of Health and Family Welfare level, with several key partners, UN agencies, development partners, where we had tried bringing in the component of assessing mental health and well-being in a very simple manner during pregnancy as well, so that you are able to identify the red flags, because that impacts how a mother is able to breastfeed post the delivery or take care of the newborn. And from the family, we usually do not get that support. And very often, you will see women who are with less of family support, less of peer support, or network support. They are the ones who suffer more from poor mental and emotional health issues, which is well documented across the low and middle income countries. And we cannot also deny the role of gender based violence, son preference. There are a whole gamut of issues which are again having their roots in patriarchy, which affect this. And we cannot address this in isolation. It has to be a continuum starting, from community, family, community, health system, back to family, community.
Thank you so much, Dr. Ghosh. You very well mentioned how a mother's mental health affects the breastfeeding. So, how can healthcare providers foster their involvement in the patriarchal setups? Like, should India consider something like paid maternity leave to share responsibility? Because, like, are Scandinavian style parental leave models feasible in our socio-economic context?
See, uh, first of all, the maternity protection that we provide in India is heavily biased to women who are in the formal sector. And very often, if you look at their socio-demographic profile, these women have certain advantages of support system. But our maternity protection benefits very often focus less on the women who are in the informal sector. But despite the conditional cash transfer, which had initially started with Indira Gandhi Matritya Sahayog Yojana, and now we have the Pradhan Mantri Matru Vandana Yojana, there is some support, but that is not enough. And parental paid leave is in the very nascent stages. Actually, getting the men on board to support breastfeeding or childcare, it has never been considered as a father's role. And that's where the problem lies. And this has to start, as I said, it takes a village to breastfeed. It's a collective responsibility of the family and society. So fathers usually are always left out even of the antenatal care processes in many instances, leave alone whatever the changes that you are now seeing in the urban sector, in the more super specialized or um, hospitals or facilities which are bringing in a new dimension. But otherwise, you will not see fathers getting engaged in this process. And the masculinity norms that our patriarchy promotes usually makes the man very shy of taking part in supporting breastfeeding, or helping his breastfeeding wife, or even prior to that his pregnant wife. So that's where the problem lies. And if you look at our community health workers, it's a female workforce. And if you look at the home visits that they make, whether in the antenatal period or in the postpartum period or as part of the home-based newborn care, you will find them, we are always targeting the mother. And to some extent, we have now started talking to the mother-in-laws, whom we understand are the gatekeepers. But fathers, even the female frontline workforce, shies away because they do not have that skill, how to engage with a man, to talk about, how to support breastfeeding, what needs to be done. And, the workers' own understanding also of the challenges of breastfeeding, particularly difficulties in breastfeeding, are often not taken into account. Breastfeeding is not a one-off thing. But it is easier when we are saying that you would be breastfeeding your child 8 to 10 times over 180 days. If you go by the number the mother has to feed the baby, it's a humongous number when she has to be breastfeeding the child. And she naturally needs that kind of support to breastfeed in an environment where she feels supported, where she is comfortable. It's a conducive home, family, and community environment for her. And her own health, postpartum often does not get much attention. We are all too bothered with the newborn, which we should be, but we need to look at them together.
Thank you so much, ma'am. Ma'am, do you think that should breastfeeding be explicitly built into programs such as RMNCH or Poshan Abhiyan, not only as a nutrition measure but as a right-based intervention? Like, could a national breastfeeding rights charter unify laws, workplace policies, and social norms? And what existing breastfeeding awareness programs are already in place in India?
I think it's a very good issue that you are raising. It's, of course, an issue of right, and a rights based framework is important both from the newborn point of view and the mother's point of view, because uh, it is the newborn's right to the optimal uh, feeding care, because this is a unique, personalized medicine, the first vaccination shot, so many flowery terms that we use as part of breastfeeding. It is also the right of the mother to be able to breastfeed comfortably, and her concerns are taken into account. And that's where collective responsibility comes in. From the antenatal period, if you are not addressing maternal health and nutrition, or preparing the mother and the family, including the father, for breastfeeding, then later on, when uh, following delivery, it becomes difficult. So you have to approach it in a rights-based framework from both. And I think the respectful maternity and newborn care charter that is there, or if you even look at the BFHI 10 steps framework, you know, this is, of course, um, highlighted as you were mentioning, but what happens is how we implement it in the regular implementation policy. I'm not saying the national level policy, there we do a good job, but when it comes to an implementation guidance on how do we take this forward, we do falter. So I think that's where this approach, that it has to be both the mother and the newborn and later the infant, who both have rights to optimal nutrition care. And there is no doubt about how important the first 1,000 days of life is.
Yes, ma'am. As you mentioned, it's even a child's right to nutrition. So, do you think is like framing breastfeeding as a right and responsibility, it will strengthen the advocacy or it will place undue burden on the mother? Like, how do we balance the mother's right and the child's health needs? And in
No,
yes, ma'am.
please go ahead.
Especially in places where breastfeeding might not be possible by the mother or it's not her own choice.
Uh, See, it is not a vis-a-vis thing. As I have been trying to say, it's the mother and the newborn diet. And you cannot just look at them separately. That's why I mentioned about maternal health, nutrition, and well being during pregnancy and even preconception. And actually, the cycle goes back to a girl child. The kind of right to adequate or optimal nutrition and healthcare that she has, that only helps her to enter pregnancy without a deficit. So that's where the mother's health is, and nutrition is very closely linked to the newborn health. And we all know the developmental origin of disease. So the preconception and the pregnancy period is of prime importance. So let's not look at, we have seen this. What happens is that child right, it's a right of both. The right of the child to optimal nutrition care, it is the right of the mother to optimal nutrition care, and also her right to breastfeed her child. And do you think breastfeeding is only helping the newborn? The mother's health benefits immensely, whether it is prevention of breast cancer or ovarian cancer or type 2 diabetes. If you look at the cost of no breastfeeding tool that came out through Alive and Thrive and Nutrition International, you will see how the benefits clearly affect the mother's health. So I would say it's not at all the right approach if we are considering, we have seen this. Women's rights activists often think that we are putting too much pressure on the mother. The child rights activists feel it is the child's right, but the mother needs support. And there can be situations which are difficult, but are we having the conversation with her to help her understand what difficulties she is facing, what kind of informed choice she can make? Because there are really very few uh, conditions where she cannot feed, but we hardly have lactation counselors, really working in the system to support the mother. And as I said earlier, also, our frontline workers often cannot give that right kind of support to the mother. And the family has sometimes a very different views and pressurize the mother. you know, a very common cause, you are not having enough milk, or your newborn is not gaining well. There will be a comparison with someone else who is doing better, gaining better weight. And then you must remember the aggressive, manipulative marketing of breast milk substitute. So that's also an important dimension that fathers, family, and community needs to be very well aware of. You will see right from the beginning in the antenatal care, particularly in urban scenarios, in private sector, well-known corporate hospitals, you are targeting the mother right at the beginning when she is very receptive. She's thinking of a newborn, how to take the best care. It's same even for a new young father to be. So we need to be taking into account these issues.
Yes, ma'am, totally. And as you mentioned about the mother's right activists, so there are many awareness campaigns and online movements around breastfeeding, and they're becoming more and more visible every day. But do they address the deeper stigma or only scratch the surface? Like, how can technology and social media be used to destigmatize public breastfeeding, but also avoiding backlash?
Uh, See, the online campaign or the social media based campaign can definitely play a very critical role in destigmatizing, you know, breastfeeding in the public space, in the workplace. And but you must also remember that, we have to back it up with the support, the skill support and skill counseling that the mother needs to do that. You know, you can, it has to create a momentum where I think, there will be people to some extent trolling you, but you would have to make the case very compelling. Why are we talking about breastfeeding? Do they know how it affects the human capital of the country for the next generation? What is the economic gain that we have? We invest $1 and we have a return of $35 if we are investing in breastfeeding. So that's where I think, if it's a collective responsibility, we are going beyond the patriarchal mindset. I think, the destigmatization or even the backlash. You see, for every, Mane, this is a little off track, but I do see, backlash or trolling around many issues around women. But, we need to be very focused with the mother and the child coming in together and bringing in this protective ecosystem of fathers, family members, and community, and then the health ecosystem. We have to be aware also of the commercial determinants of breastfeeding and nurturing care. So I think that's how it requires work. And I think we have to continue working. I think when I was your age, probably many years back in the Medical College, Calcutta, I think that was the time when I got initiated. And I think we are still trying to, you know, work through this. We are seeing changes, but there is still quite a lot to be done and many more miles to go.
As you mentioned that India still has a lot of miles to cover. So, given the particular stigma around public breastfeeding, do you think India still needs explicit legal protection, including penalties for harassment, or are the existing laws, do they just need the better enforcement?
See, the existing, we have a very good, in paper, our IMS Act is, I think, one of the best. But the enforcement, the reporting of the violation and then, you know, acting on those violations that have been reported, we are pretty weak. And I think, there are people, particularly with the Breastfeeding Promotion Network of India, constantly trying to focus on this. And I think professional associations have a big role to play here to ensure that, and once you know this, you can always bring up very explicitly it's a mother's right. And she the maternity protection, the workplace, and the creche components that are there under the programmatic and the legal provisions all allow for women to have nursing breaks and be able to breastfeed in public space. It's that, how are we implementing it? How are we looking at it? With what lens are we looking at it? Because even the gross violations are often just not report, and even if they're reported, the conviction doesn't happen often. The monitoring remains quite weak. And that has been a long standing struggle. And now with the digital marketing, things have really become tough in detecting how the manipulative digital marketing is reaching out to young mothers, mothers to be, fathers to be, young fathers. So that's an area definitely needs to be taken into account, and how you can use innovative technology even to detect such violations. Because that kind of work has happened in Southeast Asia with a AI based tool called Vivid, where they can detect the, how subtle, in what subtle manner you are violating the BMS Act. So I think these things go hand in hand when we talk about it. And family members are very often not aware. The way it is promoted, marketed, they tend to be drawn towards the benefits. And please remember that the companies use our language. They have picked up the right words that we say about why breastfeeding is important for brain development, for the cognition. They use that for their formula. That's the worst part of, the commercial determinants playing a havoc. I'll stop here.
Thank you so much, ma'am. That was wonderful. Um, as you mentioned, there is proper enforcement is required. So, in the
Yeah.
same way, like laws exist, but without accountability, they remain symbolic. So, who should take up the responsibility for monitoring these breastfeeding rights? Government, workplaces, healthcare institutions, or the civil society? And what role can medical students, doctors, and advocacy group play in lobbying for stronger legal protections?
See, I had said it in the beginning, it has to be a whole of society, whole of government approach. All the people that you mentioned need to come in with very well defined roles and responsibilities to ensure this. Because let me tell you that, you know, how many it's so heartening for me that you all as medical students are talking about IMS Act. I'm talking of 2017, and as Alive and Thrive Initiatives country director for India, we were working how to have the medical college ecosystem become fully part of this agenda. And what does our young undergraduate students or postgraduate students learn, how they get that skill training in the work. And when we had done a baseline research on various IYCF topics which they consider important, IMS Act never featured. It was kind of one of the last point that came up, because for most, how does it affect us? What are we going to do with the IMS Act implementation? So I think this is a huge and positive change that you all are talking about the IMS Act. And I think everyone needs to play their part. And we have a dichotomy because the IMS Act implementation rests with the Ministry of Women and Child Development. But you see, it is the health ministry or the health department who plays a big role through the health system or the health facilities for promoting breastfeeding. No doubt the Anganwadi workers play an important and critical role. But so when you have this reporting coming in, there is always a dichotomy who is going to own and take responsibility between the two ministries. Because, the way their responsibilities and roles are defined, there are challenges for each. And this has been brought up in various dialogues. But I have, within this group, I would say that even if we move a few steps, I have not seen this really moving, but we need the medical college ecosystem to come in very strongly, whether it is the faculty or students like you, all the professional associations who can be in the medical college or who can be in the private sector and practicing. We need the civil society groups. We even need the community based groups, the women's groups, the child rights groups, so that we can all come together to speak in one voice. That's my take.
Thank you so much, ma'am. It was a wonderful discussion from your end.
Uh,
Now, I'd like, yes, ma'am.
no, sorry, it's my daughter peeping in.
We'd like to welcome her as well.
She is very interested in these issues from her childhood. She has been attending so many college events like this that she keeps on talking about all this. Particularly if you all know Dr. M.M. Faridi, she is highly influenced by Dr. Faridi and his training on breastfeeding. So that's a brief background of her showing interest and peeping in.
That's lovely, ma'am. Thank you so much for joining us despite being unwell. Thank you for being so gracious throughout. Thank you so much, ma'am.
No, I hope it was useful. And if later on there are questions, you can please reach out to me over the WhatsApp or email. I would be happy to take questions. I don't know if there would be any further queries. Then I would ask leave to, rest for some time.
Sure,
Is
ma'am.
that
Thank
is that okay, or you want me to stay for a little bit more time? I would have loved that, but
She's
my health, but
you.
my health is not doing. I'm not at all okay. If it was not you all and breastfeeding, I would have probably said no.
Thank you so much, ma'am. Health is priority. You can take rest. Thank you so much, ma'am.
Thank you. Thank you so much. Thank you. I'll drop off wishing you all the best. I would have loved hearing Goelji. I have heard him earlier also, so it would have been nice to hear him. Thank you.
Thank you. Now we'd like to welcome Mr. Kratu Goel. Sir, would you like to opine on any of these questions addressed by Dr. Ghosh earlier?
Certainly. I think firstly, I just want to thank. Am I audible?
Yes, sir, you are.
Is it okay?
Yes, sir.
Okay. So yeah, I mean, firstly, I would just like to just extend my sincere thanks and appreciation for the work that the society is doing. It's good that you started last year, and still within a year you're doing already so many things. So great to hear that. And obviously, it's a pleasure to be a part of this panel discussion, to have this opportunity to contribute. I think I did one last year as well, so it's certainly a pleasure again. I think whatever Dr. Ghosh said, she's an expert in this field. She's been working in this for a long time. They're all very valid points. I think some of the key things that she mentioned. One of the things that she mentioned was the cost of not breastfeeding tool, which is a very important tool. If you guys have not seen it or heard about it, you should definitely check it out. It was a joint project by WHO, UNICEF, and also other agencies like Alive and Thrive. It really estimates the huge impact that not breastfeeding optimally causes. It goes beyond just the healthcare costs and looks at cognitive development, loss of future wages, decline in IQ, and things like that. So just to understand the perspective from an economic point of view, it's very important. It is also useful in using it as an advocacy measure, because I think the question when you were talking about advocacy and what can people do, what is the messaging, tools like this are very important to understand what is the actual impact, because sometimes that gets lost. If you don't have sort of real concrete values assigned, a lot of people may not be able to understand maybe some technical jargon or health issues, but in terms of money and actual cost, it's something that cuts across barriers, cuts across maybe the rural-urban divide. It also cuts across the different ministries that work to coordinate the efforts at a national level or the state level. So that becomes a very important tool. The other thing that she mentioned, which was very important, I think, is the role of the community. I think it's really important, especially in the rural areas where you might not be able to have a formal sector, you might not be able to have sort of maybe workplace environments where you can build facilities for breastfeeding. Having community support, community engagement, we know has worked in the past. It's worked for other things as well. So promoting that sort of development, peer-to-peer support in terms of facilitating breastfeeding, also advocacy and learning, is something that the community can do in rural areas to promote these activities. I think almost 88-90% of women work in the informal sector in India. So it's a large number, and that's where the role of the community becomes a lot more important. I think because a lot of the discussion was around the act and implementation of legal reforms, we forget that a lot of these acts, and I think Dr. Ghosh mentioned it rightly, was that it's implementation that we fail. And the reason why we fail is because a lot of these activities, economic activities, are happening in the informal sector. In the informal sector, it's very difficult to track, measure who's coming in, how they're coming in. The loss of wages happen when they take even one day off from work. So you don't have these paid maternity leaves or things like that in the informal sector. And that's where a lot of these community support programs or even wage assistance programs can help. So there's these different ways that you would have to probably think about providing support in the informal sector. Also, I think the social and cultural norms. I think another thing that I think Dr. Ghosh alluded to also, but the role of the family, the role of the father. What we also forget is the role of the women when they're providing support in the house, whether they're doing unpaid work that also contributes to different, and a lot of this work that they do in the house is unpaid. I think there have been studies to estimate that this is almost 15 to 20% of the GDP, the value of this work that is being done by women, which is completely ignored. It's unpaid, it's ignored, and it's also ignored when you're doing planning when you're doing maybe economic planning or health planning or social planning. So you understand that this workload also needs to be distributed evenly between men and women in the house, whether it's taking care of cooking or whether it's taking care of fetching water from somewhere, or whether it's taking care of other activities that's just involved, whether it's a rural household or an urban household. A lot of this burden falls uniquely on women. So I think to understand that and to redistribute it accordingly, or just advocate for a sort of a more equitable distribution of that workload is also important. Other than that, I think her interventions were quite sufficient. If you have other questions, we can get to them. Yeah.
Yes, for sure. So, as you mentioned, there is an importance for awareness program, and they might be hard to implement in rural settings. But the National Family Health Survey shows that the breastfeeding is more accepted, public breastfeeding, in rural and than in urban India. So, what explains this paradox, and what can urban societies learn from the rural communities?
Sure. I mean, I think overall breastfeeding or exclusive breastfeeding, according to NFHS 5 data, is about 64%, 65% across India. I think urban settings, there are a few different phenomena. I think the role of social media has definitely led to the proliferation of a lot of these unscientific facts, which people now start to follow. This is not just limited to breastfeeding, I would say. I think it goes beyond breastfeeding to other things where sort of scientific medical facts are being ignored, and and a lot of these health influencers and all might be pushing things that are unscientific but maybe to make sense for business. There's a lot of aggressive marketing. I think Dr. Ghosh also alluded to that of especially in private medical setup or in the urban setup, where there's a lot of this aggressive marketing of formulas and alternative methods. I think the way in urban settings, the way the workplace environment has maybe forced women to spend a lot more time at work, have very limited free time, or maybe the workplace is not conducive enough to support breastfeeding, also restricts their ability to do that. So I think some of these factors do play a role. I think there is an act which requires maybe workplaces with more than 50 employees to have a facility that supports breastfeeding, maybe a room or things like that. But I don't think that the act goes sufficiently. And also the implementation, as we've already touched upon, is also something that is lacking in a lot of areas. Because of a lot of these factors, I think women find it easier to maybe adopt formula to feed their baby, given the time pressures and also the social environment, where a lot of that additional workload that I mentioned, because they have to go to the workplace, then they also have to come home and maybe cook, or maybe they have to take care of other responsibilities that go beyond just their breastfeeding or motherly duties, is something that places additional burden on women. And then that forces them to maybe adopt these additional practices. Those can certainly explain why there is this difference between the rural and urban areas. But I would say even within the rural areas, I think it's not really encouraging if the total or overall country's rates is just 2 in 3 women, or about 60%. But there's still a large gap that is existing. Yeah.
Yes, sir. So what long-term national gains could India achieve if breastfeeding were universally supported, especially in terms of public health outcomes, workforce productivity, and healthcare cost savings?
Yeah, so I think there have been quite a few studies. I mean, there have been global studies as well that have estimated the loss from not optimally breastfeeding. And there have also been studies that look at how much or how cost-effective breastfeeding promotion is as an intervention. So we can look at it from both sides, right? From their side, I mean, the WHO's Choice Program has estimated this in Sub-Saharan Africa, and Southeast Asian regions, that for every $1 invested in breastfeeding promotion, it gives you $35 worth of returns on investment. So in terms of an effectiveness as an intervention, it is one of the most cost-effective interventions that you can think about. Additionally, I think the Lancet Commission and a joint project by WHO, UNICEF estimated, I think, annual losses of over $350 billion to almost, in fact, the WHO estimate was almost $507 billion a year that is lost across the globe because of lack of breastfeeding or optimal breastfeeding practices. So now, obviously, $500 billion is a large number. I think for India, when the study was done, the annual costs were about 15 billion US dollars as well. So, I mean, it's a large number, but when we sort of look into it a little bit more closely, let's try to divide this number up into what are the different factors that are contributing to this number. Well, one of the largest contribution factors to this number is the lack of cognitive development. I mean, you're all medical students, so you would know what happens when a baby is not breastfed adequately. But when we try to put an economic cost to it, yeah, I think there was a study that was done in Belarus and Eastern Europe as well, which talks about how many percentage IQ points are lost when you're not adequately breastfed for, I think it's 1 to 2 percentage points per month. And when you look at that, that translates to an annual loss of annual loss of wages and productivity across the life cycle of the human being. And this is what contributes to almost 80% of this cost. So one of the numbers. So out of $500 billion, almost 80% of this cost is coming from the loss of economic gains, loss of cognitive ability, decline in IQ, and decline in wages and productivity across the life cycle. This also leads to the other costs are from additional costs being spent on healthcare, because a lot of these issues that children develop, whether it's during their infancy, during their childhood, or whether there are long-term chronic issues that come up and develop due to the lack of adequate breastfeeding. Childcare costs contribute to the remaining about 10 to 15%. The costs that a mother has to incur then because of lack of adequate breastfeeding, whether it's developing type 2 diabetes, higher risk of type 2 diabetes or higher risk of breast or ovarian cancer, things like these add to the rest of the costs. So when we look at the costs overall, we can summarize that a lot of this costs can be saved, and a lot of these costs can be avoided if just adequate breastfeeding was followed. And the last cost is expenditure on formula and expenditure on buying alternative methods to breastfeed. I mean, I think I'm not sure what the numbers are in India, but I think in the US and in a few other of the OECD countries, there was a study done which looked at annual costs that range between, specifically for spending on formula, right? Annual costs range between somewhere between $1,000 to $3,000, or per month it ranges between sort of $50 to $300, depending on the age of the baby and the amount you're spending on the formula. So these are massive costs. If you translate them for an average Indian household, spending $10,000 a year, it might be more than someone's salary, or especially in the rural areas, even if the formulas are relatively cheaper. Again, given the implementation sort of weaknesses we have, we also don't know whether these formulas are being tested adequately, whether there's contamination, other issues that come in, specifically when you're trying to feed these formulas to babies. So a lot of these costs add up, and that's what creates this enormous burden.
Yes, sir. So as you said, sir, what are the economic saving, as you mentioned, the formula, lower health care costs, and how do maternity leave and workplace supports affect the breastfeeding and women's workforce participation?
So yeah, well, one of the, just to summarize, previously, I think there are four main savings. One is the point I mentioned the last, which is savings of formula. The other two are sort of fewer hospital visits and healthcare costs for both the child and the mother. And then the last one is, of course, the biggest cost is the increase in IQ and cognitive development, which leads to higher wages across their lifetime and higher productivity. So when you don't breastfeed optimally, obviously a lot of that is lost. In terms of looking at workplace, so when we look at the workplace, I'm assuming you're talking about the formal workplace environment. in terms of the formal workplace environment, I think India, like Dr. Ghosh also mentioned, I think India does have a relatively robust act. It also provides, in comparison with some of the Western countries, it actually does provide sufficient maternity leave. I think the US only provides about 12 to 15 weeks by law, and then it depends on the organization. But a lot of the places in the US don't do that. Of course, Canada does is at another end, which provides more than a year of paid maternity leave. So there are variations, but India is sort of on the right side in terms of providing adequate support for maternity leave. But I think there's particular research which focuses on adequate paid maternity leave, and it looks at also sort of how provision of maternity leave leads to workforce retention. I think there are it's in the benefit of a lot of companies to ensure that women are supported during the phase of breastfeeding, which also ensures lower costs for companies to replace workers. I think there's about 20% costs that come from attrition. And if women are not provided adequate support, they have a tendency to drop out of that role or move to other places. And the cost of replacing a worker is also quite high. It's like I mentioned, almost 20% of whatever the salary that worker was drawing. So if we can assume someone was on a salary of $50,000 a year, replacing them would cost, replacing one worker would cost them about $10,000. I think what companies can do is to ensure, I think there are requirements for companies with more than 50 employees as per the 2017 Indian Maternity Act. But I think that should sort of go beyond just 50 employees. I think there are sort of gains to be made by expanding the coverage. There are certain physical requirements, sort of basic physical requirements that any sort of facility should have, which is maybe just a private room where breastfeeding can be facilitated, the ability to have sort of running electricity, maybe a clean, comfortable chair, just maybe some storage facility, maybe a refrigerator where they can store the pumped breast milk, things like that. Additionally, I think companies can also maybe promote and advocate for breastfeeding, maybe counter the advocacy that is done by formula selling agencies, maybe protection from discrimination or sort of protection from stigma where women are taking breaks because obviously during the day they would have to do this a few times, and so just protection from discrimination, and maybe just have clear guidelines around this for all employees. I mean, that's for the formal sector. For the informal sector, of course, it's a different story, but for the formal sector, that's what they can do. Yeah.
So talking about the informal sector, like many women in India work in the unorganized sector without the maternity protection. So what are the economic implications of this gap, both for families and for the country?
Yeah, right. So of course, like I mentioned, almost 88% of women, almost 90% of women are employed in the informal sector. So that's, I mean, that's a large number. It represents almost 200 to 250 million women who will be lacking access to the formal maternity protections. It's a huge, and this is divided across, I wouldn't say this is just limited to urban areas. I think urban areas, of course, we know people working in factories or providing domestic help services, things like that. But also in the rural areas, it goes women employed in farming or other sort of rural occupations. It's the economic impact, like I mentioned, is well, one for women. There's no paid maternity leave who are working in these informal sectors. A lot of these women are maybe forced to or compelled to return to work for fear of loss of wages. Every day that they miss from work is something that they're missing out. So within 2 to 3 weeks, sometimes even less, they are forced to return back to work. Usually it's manual labor, as compared to what the recommended 6 months would be, where they would be doing exclusive breastfeeding. So I think a lot of this costs them. It costs, well, what it does is it costs them complete loss of wages when they're missing work, So there's this loss of wages that this is the cost on the family. Additionally, due to the lack of optimal breastfeeding, there's higher healthcare costs, that the child is more susceptible to different kinds of diseases, inadequate development, inadequate nutrition. And it also leads to an impact on the health of the mother itself. So again, there's this increased economic cost that is placed on the family. When you add it up and you look at the long-term consequences, again, what I mentioned, one of the largest costs comes from cognitive decline or lack of cognitive development. And this really affects future earning potential and future outcomes, future productivity. It also leads to higher illnesses and healthcare costs, both for the mother and for the child. And I think what happens is that it perpetuates a cycle of intergenerational poverty. So every generation is suffering from the same issues, and then it's a cycle that you're not able to get out of. As a country, if you add it up, I think it leads to a huge loss for the country in terms of the GDP that the country could have increased if people were more productive, if they were more cognitively developed. It also produces a huge burden on the healthcare system because you're trying to continuously combat the same issues. There's higher rates of childhood infections. There's higher rates of malnutrition. There's increased maternal morbidity as well, at least to chronic disease burdens that can happen as well from suboptimal intervention. And then also it places a burden on emergency care that could have just been prevented by simple support. It leads to you rushing to emergency for more complicated or complex interventions, which could have been prevented or avoided.
Sure, sir. So the lack of dedicated breastfeeding spaces in public institutions like transport hubs, hospitals, malls, airports, and workplaces forces mothers into uncomfortable situations. Should these spaces be legally mandated in such public spaces, or could this lead to further segregation of the mothers?
No, I don't think it would lead to further segregation. I think it would be a good idea to have some of these some of this sort of infrastructure that is available, because I think, especially in public places, because it benefits, at least in the urban areas, it would benefit both women employed in the rural sector and in the urban area, both employed in the formal sector and the informal sector. I think you have these facilities which are in public areas, and I think these can be developed as part of a public-private partnership. These can be done through a blended financing mechanism, whether you're doing it through state government funding or central government funding, or even through funding from development aid agencies. And then it creates a safe space for women of all strata of society to access them, especially in these areas. So I think it would be certainly a useful intervention to do so.
So thank you so much, sir, for this lovely discussion. Now we open the floor for questions. If any of the participants have anything to ask a panelist, kindly raise their hand or share the question in the chat box. Uh, y- yes, Moira, I think she has a question.
Yeah, good evening, everyone. So, sir, I wanted to ask, given your experience in health policy evaluation, what one change would you prioritize to better protect and promote breastfeeding rights worldwide? Thank you.
I think the one change that is most important, not limited to just breastfeeding, but just looking at healthcare as a whole, is to consider healthcare as an investment and not a cost. I think a lot of the times, most countries, governments consider healthcare as a drain on the economy, or spending on healthcare as something that is a social program. But I think if the messaging is more around considering healthcare as an investment, which has excellent returns on investment. I mean, even with the example of breastfeeding, when you invest $1 in breastfeeding promotion, you get almost $35 worth of benefits back. I think that's the messaging that is something that should be widespread, something that should be thought of in terms of all interventions, not just limited to breastfeeding, and just thought of healthcare as investments into the future generations and future productivity. Once that messaging is more prominent, I think you will see a lot more political action supporting some of these interventions.
Does anyone else have a question? Yes, Shravan.
Good evening, sir. I wanted to ask that if someone like me, coming from a healthcare background, wanted to explore a career in health economics and policy the way you have, what would be a good starting point? And how do you think clinical or public health training adds value in that space?
Well, if you want to consider health economics or as a subject, I think there are different programs, there are different universities that focus on different topics. Maybe if there's a particular area of your interest, uh, that is something that you can pursue. Having a background in healthcare is not essential. So I didn't have a background in healthcare personally, but after working for almost 7-8 years, you tend to pick up things. It depends on what the role that you're looking for, and depends on what kind of work that you want to do. If it's purely economics based, then having a healthcare background is not compulsory, but certainly having it does help you understand maybe the disease pathways and the way the disease is working, and maybe interventions a lot better. But it's not a requirement. Yeah, I would say that. Thank you.
Thank you, sir.
Yes, Aditya, you may ask a question. Um,
Am I audible?
yes, you are.
Good evening, sir. I wanted to ask that coming from a country which is still catering to the needs of someone people who are still economically not very strong, what's the most efficient way to provide the incentive? Should we provide incentive to just the vulnerable ones, or we should go for a universal scheme for throughout?
See, I think most countries or countries that have had successes with programs always start, especially with incentive-based programs. I think there's a lot of examples across the world. They start small. So I think any country that wants to implement a program, which is an incentive-based program, it's a financial incentive, the focus should always be to providing incentive to the most vulnerable populations first, looking at the benefits of that program, and then if the fiscal space allows you to expand that program further, you build upon that and expand it. I think, of course, I mean, you can look at the example of Sierra Leone. They've had programs. They have a very good maternal program, and then now they started with just children under 5, vulnerable mothers, but then over years they've expanded it to include adolescents as well, include other interventions like that. So there are examples around the world, but almost all of them focus on starting small. So I think that's a better strategy to especially for a country with like India. Even developed nations, unless you look at a country like Brunei or Jordan, especially these oil exporting countries who have very high GDPs. Apart from these, there are always programs across all countries where there are certain limits to the beneficiaries, whether the limits are in terms of waiting times, whether the limits are in terms of financial incentives. You can place different kinds of restrictions, but always programs come with restrictions. So no country, except for a few exceptions, like I mentioned, will be providing benefits to everyone for everything. It has to be focused, and it has to be whatever money you have has to be spent wisely.
Thank you, sir.
I think Kusmita had a question. You may please go ahead.
Good evening, sir. Good evening, everyone. This is Kusamita. My question is, what models of community level support infrastructure, like the local centers or the healthcare networks, how do they have, or have they do they have the potential to scale in India?
Certainly, I think community-based support or community-based healthcare programs have massive potential. We've seen examples of community-based self-help groups in different industries supporting economic development for women, supporting educational development for children, and even supporting health development and health programs in rural areas work. There are examples available. I think that's something that should be complemented. I think there are certain limits to the formal health sector or even the government's outreach. After a point, I think it becomes incumbent upon community programs to provide these supports structure. And I think given that a lot of these, especially in rural areas, I think a lot of the burden falls unequally on women. I think starting with women self-help groups and peer-to-peer learning, peer-to-peer education and advocacy is something that has massive potential, and there is sufficient example of success across different social programs. So certainly something to build upon.
Thank you, sir.
So I think that was all for the questions. Now I'd kindly like to request our audience and all the participants to switch on their camera if they are comfortable so we can click a picture. Thank you so much, everyone. So, before we conclude, we'd like to remind you that the post event form has been shared in the chat. Kindly fill it out to receive your certificates and send a proof of attendance. The meeting will remain open for the next 5 minutes, so you can complete the form. And thank you once again for joining us today. And we truly hope you found the session insightful and engaging. As we come to the close of today's discussion, it is evident that nurturing rights go beyond individual care. They encompass the collective responsibility of families, communities, and society in ensuring dignity, equity, and well being for mothers and children. On behalf of SIMSOG, I especially want to extend my heartfelt gratitude to our esteemed panelists for their invaluable insights and reflections. A special thank you as well as to our participants for engaging in this meaningful conversation. Thank you so much, sir. Webinars like these are of immense importance for creating awareness, and hopefully one day our country will see the change with all these legalities in place. Thank you so much, sir.
Thank you.